to bring on stage our physician and guest today, Dr. Kovacs. So let me bring him on. Hi, Dr. Kovacs. Great to have you on. How are you doing?
Hey, Omar. Good. Thanks for having me on. Excited to talk with you tonight and talk about this fantastic technology we've been using.
Absolutely. And then as people come rolling in, I'm going to just, as always, ask them, go ahead and drop in the comments, where are you joining from? We'd like to know the city. We know we have people joining from all around the world. But in the meantime, Dr. Kovacs, give us a little bit of your background and as an intro.
So yeah, I'm a pulmonologist, interventional pulmonologist and advanced bronchoscopist. I've been in the space now, boy, for a long time. I've been doing this since about 2009. So I was kind of there from the beginning of navigational bronchoscopy with the old super dimension system. I had the benefit of being the first person to ever utilize the Monarch bronchoscope in a commercial space. We kind of started the advent of robotic bronchoscopy and been able to continue to work with so many people to advance this field. And we all were looking for that cutting edge of being able to eradicate lung cancer eventually. And each one of these foundational steps have moved us closer. So working with technology, again, such as Van Gogh and CellTivity, really helps try to move that needle forward. I'm excited to share with peers and people who are learning this for the first time about the benefits it really has brought to us, what it can do.
Absolutely. And something that was very interesting as I was learning about the interventional pulmonology space is that there's a lot of technologies that show that your tool's in lesion, but this is the first that shows lesion-in-tool. Can you kind of expand a little bit more on that just for the audience that maybe are not interventional pulmonologists and they're learning?
Yeah, no, Marty, when we look at this, we've had so much technology kind of come forward to get us closer and closer to smaller and smaller lung nodules. Lung nodules have been lung cancer being the deadliest cancer out there, more deadly than the next 4 cancers combined, that the ability to diagnose it earlier when it's at smallest, but also most difficult to reach stage has been very difficult for us over the years. So we have robotics and advanced imaging and things that have gotten us to the point where we can actually visualize that our needle or forceps or whatever tool we're using is in the center of that lesion. But many times, even though we were there, we weren't getting the final answers we were expecting. So although we knew that our tool was in the lesion, we'd never had the ability to actually see what was in that tool and if what we were getting was actually lesional. And that's what I really want to hit on tonight with this technology and really start to share our experiences with our ability to now do that.
Fantastic. Yeah, and we'll get started in a moment. We see a lot of people commenting, so I'll just kind of do a little highlights. But Dr. Kovacs, I was wondering, is a good way to look at this is that this feels kind of like a PET scan for cells. Is that the right way to kind of look at that?
Yeah, exactly. That's what PET scans become very helpful to us because it gives us a visual representation of cellular metabolism. It does it on larger images when we start looking at this throughout the entire body. But having that same type of mental imaging and that same type of muscle memory, when we come to looking at these, Van Gogh has been able to tell us that on the cellular level at the time of biopsy. So the same thought process we do looking at PET scans, we can now easily equilibrate over to the tissue that we're biopsying in real time in the room, make our own assessments of whether or not what we're getting is lesional.
Fantastic. Now, before we get started, just to give a little shout out to some people who are joining and where they're coming in. We got Adam coming in from Boston. We got Logan from Cranberry Township. We got Dr. Mazen from San Diego. Dr. Vinod Khatri coming in from Toledo, Ohio. Dr. Jatan Shah from Jamestown. So a lot of people, thank you all again. Please comment, share where you're coming in from. And as we go through the broadcast, if you end up with a question, please drop it in the comments. Even if you're watching this on replay, we will be checking the comments so we can follow up to answer those questions. So drop your questions in from now and then during the broadcast. And Dr. Kovacs, let me let you take over to walk through some of the deck, and then we'll get into discussion.
Oh, thanks, Omar. I appreciate that. Happy to do it. So again, thank you everyone today for coming in and listening to our kind of discussion today on the impact of metabolic activity and how it's really driving a precisional change in diagnostic bronchoscopy and how we're really using it throughout our procedure and every procedure to be an important tool that we use. And to me now, just as important as my robot, my imaging modality, because it really does help drive accuracy. Because one of the issues when we deal with this is the problem of lung cancer diagnosis. Again, being the deadliest cancer out there and the one that's hardest to reach in the periphery with many tools has led us to have this major investment for early lung cancer diagnosis. And lung biopsy comes at a high cost, and many centers becomes a loss leader procedure. But early detection drove thoracic surgical volume, and we pushed harder and harder to really get that diagnosis, to get technology that would help us confirm we had true tool and lesion. The problem is when we sent that tissue over to pathology, we started to go through the ROSE process. And with ROSE, unfortunately, many times it can be ineffective to no fault of the pathologist. But when you hand them a small speck of tissue or a small smear in a slide and expect them to diagnose cancer within several minutes in your room, that goes beyond a lot of what their training has been able to allow them to do. And they're only looking at a small piece of tissue. And when they look at it, they have to stain it, which damages it and does not allow them to do any further tests other than what we're staining at the time of the procedure. And that's assuming you have availability. About 40% of the centers right now that do robotic bronchoscopy don't have any ROSE evaluation ability. And you will never have one pathologist look at a ROSE slide and give you any type of assessment for true next generation sequencing sufficiency. And the real reason that this is a problem is because, as many of you know, when we have a lung nodule, it's not just one uniform ball of cancer. You have areas of malignancy and inflammation and necrosis. And your imaging can tell you your needle is in the lesion. But if it's in the part of the lesion that's cancer, you do get diagnostic material. But you can be in that exact same lesion, the exact same part. And if you hit an area of necrosis or inflammation, it now is non-diagnostic. So no ROSE testing will ever allow us to get true tissue quality. And that cannot be evaluated by advanced imaging alone. So let's step back a little bit and look at Van Gogh. I find the name of this technology fascinating because when we start looking historically, the Impressionist movement of the 1880s revolutionized art by capturing light, emotion, and perception rather than just rigid realism. And artists like Monet and Renoir used innovative technologies to depict the world as they experienced it rather than just a precise representation. And Vincent van Gogh took that even further, using bold, expressive brushstrokes and vivid colors to reveal the energy and movement within static subjects, to reveal what lay beneath the surface. And as in Starry Night, he didn't just copy reality, he reimagined it. He urged us, do not quench your imagination. Do not become the slave of your model. And although the technology behind Van Gogh may be new to us, the science behind this technology is not new at all. When you look at the scientific foundation of this, Otto Warburg, back in 1931, where he won the Nobel Prize for discovering respiratory enzymes. But his real legacy actually laid in the Warburg effect, which is what the technology behind Van Gogh is based on. And that cancer cells prefer glycolysis, even with oxygen present, fueling their rapid growth. And Warburg saw this metabolic shift as cancer's root cause, laying the groundwork for an oncology focus on metabolism as the hallmark of the disease. Now, as we look at the evolution in our field, where the first rigid bronchoscopy took place in 1897, and flexible bronchoscopy grew in the 1960s, EBUS in the 1990s to 2000s, and the advent of robotics in 2018, as well as the explosion of imaging from the first X-ray that Röntgen took in 1895. You saw a massive push towards CTs in the 70s, PET scans, ultrasound, all of these build together and then started to collaborate with what we do. However, pathology stuck in the early 1800s with fixation, and in the early 1900s, H&E staining came around. ROSE wasn't even started until the 1960s and took over a decade to become even utilized within an academic center. Within our space, there has been very little pathologic innovation. And that's really up until Van Gogh. And in 2022, where dynamic cell imaging really started to take hold, this was the first real-time metabolic assessment and the first significant pathologic innovation in our space since the 1980s. But why is this important now? And I think it's because as pulmonologists, we've been slaves to our own outdated models for far too long. We've been battling low diagnostic yields in bronchoscopy, hovering around 60 to 80%. And despite all of these advancements in robotics and imaging, our rapid on-site evaluation leaves us in the dark with inconsistent results, damaged samples, and no real-time cellular insight. But going back to Van Gogh's daring vision, this device sheds lights where there was shadow. And it offers us a fresh perspective on cellular metabolism to really confirm not just that our tool is in the lesion, but that our lesion's in the tool. And this technology, named for its vivid, swirling cellular image reminiscent of Van Gogh's art, it also embodies his mindset, breaking free to see differently. It's a point-of-care tool that lets us as proceduralists assess the entire biopsy at the cellular level without changing any pathologist's workflow or even requiring their presence. So what do we do? How does it work? Well, what we do is we take the full biopsy, FNA, tissue, cryo, whatever you like. You put it on their proprietary holder. And in about 2 minutes, using dynamic cell imaging in full field OCT, it measures the intracellular motion that's tied to metabolism. No stains, no damage, just a heat map where disease cells glow brights. And this pattern recognition, like the PET scan for cells, is that cancer cells show areas of high activity. Normal non-metabolic cells don't. And it confirms really we're getting the right material, giving us real-time confidence. And by doing so, minimizing risks that having these devastating patient interactions where the times occur where we have to tell people we missed a diagnosis, or we have to do another procedure, or do this again. And by looking at all types of biopsies with light alone, this can scan down to over 150 microns in size, which is why you can look at multiple different tissues. And a standard transbronchial biopsy takes us about 2 minutes to get these bright, vivid color images. No slicing, no staining. And we preserve tissue or final pathology and sequencing, and allows us, the proceduralists, to assess biopsy adequacy during the procedure. I don't need to diagnose the type of cancer in the room. I don't want to. I'm not a pathologist, but I don't need to be anymore. I need to make sure that I'm getting the right amount of tissue at the right place so that pathology can make the diagnosis that needs to be made. And everybody wins, especially the patients. So let's walk through how this works. So this is my bronch suite. This is my nurse. We've handed her a forceps biopsy from the Tram's bronch. Put a small amount of Hank solution on side of a small glass where the tissue is, just to make sure that it holds in place. And this is with the older technology where we actually put a glass slide on top of the holder and screwed it in place. The Van Gogh system actually has a newer, more advanced single-step process, but even this only takes several seconds. And by making sure that the tissue is on the right place, once we insert it into the Van Gogh device, it accepts the sample holder, and we can start to scan the tissue. You can scan a small piece of the tissue, or you can scan the whole thing. We start by using the FFOCT technology to really start to give us a grayscale, but a real-time movable grayscale. We can decide if we want to look at a small part of the tissue or the entire piece of tissue itself. And once we find the amount we want to look for, we can start scanning with that bright colored heat map to start to get our eyes to pull toward the areas of enlarged cells that are bright and yellow. We can evaluate within minutes the cell's morphology, their pleomorphism, whether they're clustered together, their size, whether they're large or small, visible nuclei, but really your eyes really pulling toward the yellow color. With a simple computer algorithm, we can switch that over to a standard H&E view, where we call histo view, which gives that if that's more your preference. And without ever touching the cells through digital algorithms, we can start what's called virtual sectioning, digging into the tissue virtually, just with the computer and lights, where no rows will ever go. And by looking at these types of evaluations and seeing the various patterns and differences, we start to get an adequacy assessment that we are in the right place and that we are starting to see the tissue that we've always wanted to see, to know that we got what we came for. So through this simple point of care confirmation, this gives us real-time verification of that lesion-in-tool directly in the procedure suite, eliminating a lot of uncertainty, a lot of guesswork, a lot of time, and a lot of extra procedures. And by using DCI and FFOCT, and by creating these metabolic heat maps, we can do so without ever having to place a stain or damage any tissue. Every image that you just looked at, and every one that I ever look at, always goes to pathology at the very end. Nothing is wasted. It comes right out of the device and goes right into our specimen containers. And by looking at these vivid, swirling cellular images, we can for the first time reveal the hidden metabolic activity, functioning as a PET scan, if you will, with metabolism, but on an individual cellular level. And what we start to get with simple pattern recognition, with very little training that really is required, because we have the comfort level of knowing what PET scans look like. And by looking at these images after about 5-10 cases, when you start to see this type of a pattern of the area of blue-green that we know are normal bronchial cells, and the bright contrast of these enlarged yellow appearing cells with orange visible nuclei that are all different shapes and sizes, part of their pleomorphism, that are clustered on top of each other. These are the patterns that we see with malignancy. And we see this time and time again. And it doesn't matter if it's a nodule, if it's a ground glass opacity, if it's an FNA, a forceps, or a cryo. All of these specimens shine brightly when high metabolism is there. And it got me wondering, how many times have we been inside of a nodule? Inside, we know we're highly suspicious this is cancer. And we got the tissue that was there. We've handed it off to pathology, and they say, well, all I see is reactive bronchial cells or inflammation. I don't see any malignancy. I'm like, how can that be? I'm in the center of it. I've got a cone beam showing me I'm in the center of it. And it's because of that non-uniformity of these cancer cells. So this image is one of my transbronchial biopsies. It's the same one on the left and right, one with DCI and one with histoview. And if you look at this, it all looks kind of yellow. It all looks different. And if you look at one area of the cell, what came up on the FNA or a touch prep, and you start to see an area like this, it's metabolically active, but the cells are small. They're all kind of the same size. They're clustered together like a bunch of grapes. This is the hallmark of inflammation. But only several microns away, we see a very different pattern. Enlarged, pleomorphic, clustered cells with highly visible nuclei that were so close to the area of inflammation. And if your FNA got the prior and not the latter, you're going to get a call of inflammation. But cancer is still there. And now you can see it all at the time of the procedure. And we looked at this. So this was one of our, this was a poster we presented just at ATS this year. And what we did was we took 94 robotic bronchoscopy cases. This happened to be with my prior Monarch device that we used. And what we did, we did a 1-to-2 concordance ratio match study. And what we looked for is, of the 94 that we used CellTivity, and this wasn't even Van Gogh, this is the precursor to CellTivity, without the advancements of Van Gogh, just of our initial experiences. Took our first 94 cases that we used it. And we looked back at our other 1,000 robotic bronchoscopy cases, and we matched up areas of lesion size, region, lobe, BMI, and other demographic modalities. And what we looked for were several things. We looked for success probabilities of CellTivity versus rows. And we also looked for different group analysis of case time, as well as concordance with pathology on looking for areas that were considered indeterminate. Because it's always it's a big red flag for using rows, is the fact that having high amounts of indeterminate biopsies at the time. And what we found was that when we looked at case time, we had a statistically significant improvement with CellTivity and Van Gogh than with Rose, saving on average about 17 minutes per case. And then we looked at the amount of indeterminates. We were statistically significant improvement of indeterminates that we saw, that we did not see with Van Gogh and CellTivity, the Path did see when we compared them out. And it was amazing to me as well, is that when we powered this through, compared to the gold standard, which is Rose, we were powered to non-inferior just in the study alone. And one of the most interesting things I found in this was, of those 94 cases, when we look back at them, we had 12 cases where at the time of the biopsy, I saw cells that I was convinced were cancerous. Didn't know what type at the time, but considered they were cancerous and kind of had an idea of what we were dealing with. And the final path of those 12 cases, not Rose, final pathology was read as negative. And because I had CellTivity in Van Gogh, I didn't believe it. I didn't believe that there's some reason, which they're just, I know there's cancer here. So these patients, we took the next step. We had them, whether they got resected, whether they had biopsy through different modality, or whether it was just a conversation with pathology. It allowed them to look again and look deeper. In all 12 of those cases, came back as malignant. And it was the same type of malignancy that we thought we saw at the time of the biopsy. So how many times have you all sent tissue and convinced you were in it, and final path came back as negative or indeterminate? And the reason is not their fault, is the fact that when we take all of our biopsies, they're spinning it down to a block, and they're only taking the first 3 to 5 microtomes off the top of that block. They cannot exhaust the specimen, because if they did, they wouldn't have any for immunohistos or moleculars or anything else if they wasted it all looking for cancer. So they don't. That's not the standard modality. But when they do look deeper, or that cancer is deeper into the puck that's there, it's not that you missed it. It's just that it was hidden from standard pathologic techniques. And we start to look at this as the needle in the haystack modality, right? So this is a case I did just recently. So this was one transbronchial biopsy. We looked at a large piece, and you see a lot of blue, a lot of that kind of standard blue, negative looking non-metabolic areas. So your cancer many times becomes a needle in a haystack, because if I were to do a touch prep on this piece and 95% of it is non-metabolic activity, what do you think the pathologist is going to see when they look at the touch prep? They're going to see the 4 dirty words of the Bronx Suite: benign bronchial epithelial cells. But if you want to find a needle in a haystack, you can do it one of 2 ways. One is you can burn the haystack, which is what we do with standard Rose. We take biopsy after biopsy, tissue after tissue, taking time and increasing risk every single time we do that, until eventually, hopefully, that pathology is going to give us an answer. And hopefully that procedure is going to be safe enough that that answer was worth it. Or there's a safer way we can do it. You want to find that needle in the haystack, you bring a magnet and you find it for yourself. Because at the end of the day, we are not just tissue foragers. Our goal, we are the ones who are sitting in front of that patient, taking their history, knowing the cancer prevalence in our regions. We looked at the CT scans. We looked at the PET scans. We did the procedure and we know what we found. And now Van Gogh is allowing us to rethink our role in the diagnostic process. And really, no longer are we just trying to access tissue for pathology, but we're evaluating adequacy in real time. And this shift empowers us to make quicker, more informed strategic decisions about how we are conducting our procedures, ensuring that we collect this diagnostic quality tissue and giving us the confidence now to have meaningful conversations with pathologists that we never could have before. And when these things don't align, those conversations are so valuable, because pathology doesn't want to miss this either. As much as we hate when they don't call cancer, one of the biggest fears for them is calling it when it's not there, which many would say is even worse than saying it's not there when it is. But by integrating this new level of diagnostic precision into our workflow, we're not only improving our patient outcomes, but also the way that we're evolving diagnoses. So I think it's important to, in closing, I like to remember Van Gogh. Two of his quotes, this one here that we said earlier, but another one I loved was one that said, he said, "I often think that the night is more alive and more richly colored than the day. Our field has been in the procedural dark for too long. The Van Gogh device illuminates it, and it frees us from the rose's constraints to achieve precise, efficient outcomes. The Van Gogh device illuminates us and liberates us from rose's limitations to deliver precise, efficient care and deliver that equitable care that we demand for our patients. Because if your center has rose, this device enhances its accuracy. If rose is delayed, it eliminates wait times in runners. And if you have none, it brings real-time metabolic insight to every biopsy. And it democratizes our high-quality care. I look at this not just as a tool, but it is our brushstroke into the future of bronchoscopy. I'd like to thank everyone for coming on today for this conversation. I'm happy to answer any questions that you have. I'm looking forward to the conversation and discussion.
Love it. Thank you. Dr. Kovacs, that's fantastic. And I love the blending of both art and science. For those who are watching either live or on the replay, this is your chance. Go ahead and drop a question in the comments section. And if you're interested to learn more, go to CellTivity.com. I'm going to kick it off first. And I'm going to, for those, there's some people who don't want to be public, feel free to direct message me on LinkedIn. I'll be watching that. But Dr. Rose, first thing I want to talk about is, you talked a lot about, let's say, the challenges with on-site cytology and the role of Rose in your practice. And I'm wondering, when you think about Van Gogh, how does it directly compare when it comes to two things? Like, one is diagnostic adequacy and then workflow efficiency. And more specifically, especially like when it comes to centers where, let's say, like Rose isn't quite available.
Yeah, it's huge, because if you don't, many places that, let's say you don't have any Rose at all, your only recourse is to take multiple biopsies and hope that you've taken enough that pathology is going to find it at the end of the day, because you don't know when you leave that procedure if you had enough, or if you've even gotten to where you've needed to be. So this now gives us that adequacy assessment so that we can look at this and say, yep, I don't need to take 15 biopsies. I got in the first 5, because every one of those biopsies does increase risk. No matter how you look at it, you do take a small but real risk every time you do another biopsy. Other places may not have pathology in the room itself. Like my place where we just have our pathologists, they're just in limited supply. So they would stay in their lab, and we would have to take tissue and actually have a runner physically run specimens, slides up to them. And we wait in our room 10, 15, 20 minutes, and they'd call back. And sometimes they give us a diagnosis and sometimes they wouldn't. So now you're doing that every single time. So now you're increasing anesthesia time, you're increasing case time. And that's become a real hot button for hospital administrations, that too, because not only do you increase anesthesia time and risk, but like anything, time is money. And to run an OR right now, table stakes is anywhere from $60 to $100 a minute just to have the lights on, the people in there, and it open, not counting all the other technology you have. If you're in an endoscopy suite, you may shave $40 off that, but still you're in about $40 to $60 a minute. It's expensive. So if you're shaving 17, 20 minutes every case and you're adding another case, hospitals find that a huge value now. So you've got that benefit. But even if you have Rose, even if you have fantastic Rose, this now is a screening tool, because what many people don't realize is many cytopathologists and cytotechnicians can only look at so many slides a day. I can say it's like 100, 150 slides. So if you have 5 cases and they have to look at 15, 20 specimens, and that's usually not just you, they're jumping around to other rooms and doing things. You may have them in the morning, but you may lose them later on today. So now you've changed the quality of care. So if your 8 a.m. patient now has different care than your 3 o'clock patient. And that's not fair.
That makes sense. That makes sense.
So it builds that process throughout.
Got it. We got our first question, but before we jump to it, I want to give a little bit of a shout out just to show I guess the interest and excitement of this. We have Dr. and I just saw her, Dr. Veronica Manolash, who's coming in from Bucharest, Romania, where it's 2:30 in the morning right now. So, Dr. Manolas, thanks for joining. If you have a question, please drop it in.
Yes,
so the first question we got is Dr. Curtis Quinn, who's a thoracic surgeon. And I'm going to bring up the comment, then I'll take it away because it's going to cover our faces. But the comment is, amazing technology, Dr. Kovacs, is really exciting. How many specific specimens and cases do you need to do so that you're confident on malignant diagnosis? Also, do you think this can reduce the time of lesion ablation, such as with galvanized or ELIA PEF system, by identifying necrotic tumor from live areas? So I'll take that away, and I'll let you cover the first question. I can reread the second part to you after.
No, I appreciate that. No, Dr. Quinn, absolutely. I mean, when we start looking at this technology, it kind of all depends on the size of the nodule. If we have a small nodule, many times those are almost easier in a way, because if you can remove a good portion of that nodule and actually for the first time evaluate the entire biopsy, you may find in that first pass that you have the diagnosis. We see that very often. But we may have other times where, let's say it is a little bit larger, or there's a lot of inflammation around it, or it's a ground glass nodule where we may have some inflammation that's kind of mixed in there. Those first couple of passes may just be inflammation. So we're actually redirecting our procedure. We've now become more strategic. We're not just kind of throwing our line out and hoping we get a bite. We're actually able to redirect our robotic system. So if we're not getting the answer in one direction, we may have to move it over just a couple microns, a couple centimeters, and just kind of get it from a different area. A couple of millimeters, I should say, and then biopsy that, and then you find it there, and that's where you focus your tools on. So again, you now have a strategic portion of that. And Dr. Quinn makes a fantastic point. I mean, he's one of the forefront people with PEF and ELIA when it comes to pulse electric field and treatment of lung cancer. And he's absolutely right that if you have that needle and that tool inside of a nodule where, let's say, the tip of where you're delivering that energy is just necrosis and dead cells, you can deliver as much as you want. It's not going to change anything. So even though you're treating a nodule, you don't know if you're treating the cancerous part of the nodule. So I think Van Gogh brings a huge piece of the puzzle there, because by going in, taking a specimen and seeing that you see cells that are highly active and malignant, not necrotic, not dead, and with a known diagnosis of cancer, you could easily redeliver that tool back into that same area. So now you're maximizing an already minimally invasive and fascinating new procedure that's allowing us to really move the needle, no pun intended, on lung cancer treatments that we're seeing here. So I think that this technology goes hand in hand with advanced therapeutics require accurate diagnosis. And I think this plays a very vital part in the role of all of that.
Fantastic. And Dr. Manolas has a question all the way from Romania. Before we get to her question, I wanted to just sort of touch a little bit deeper on the use of ELIA. So, I did hear about an account where using the ELIA system from Galvanize, that in the first few procedures, there were some delays in terms of getting the appropriate tissue to frozen, which sort of delayed the overall procedure. Like for you using ELIA, did you notice some kind of a reduction in procedure timing when you use Van Gogh in conjunction with it?
So ELIA is still, it's still getting new to the market, as is Van Gogh. So what we're doing now is we're just now starting to see centers that are starting to use both. And I think now it's starting to, because again, this is a real-time, fascinating, evolving piece of the puzzle here. And I think what they find with ELIA is that, you need to treat at least a majority of that nodular mass to get a better effect. So right now is kind of based on tracks of kind of volume. You want to treat a volume of the nodule, but maybe where you get to, let's say, 60% of it, you want to treat it in order to get to the inadequate response. But of that 60%, it's got to be 60% that's cancer. So I think if you have another tool that's going to, again, make sure that you're delivering this technology that's really kind of showing to be, very beneficial, but you want to get it in the right place. So if you're ensuring you're in that right place there, and again, we didn't really have much other than external imaging, other than having your combing, knowing your needle's in the right spot, but knowing if it's in the right spot of cancer. Now you're allowing this technology to really shine, because every time it takes time to deliver these energies, each one of these pulses, and you want to deliver enough and make sure you're doing that, but you want to do it in both an efficient and proficient way. And that's really where I think the two of these marry very nicely together, and they're going to show to be an added way to benefit both sides.
Right. Right. So let me bring up Dr. Manalish's question. So Dr. Manalish asks if there are any specific requirements on how to handle the specimens while testing in order to preserve the sample. And she says, thank you and wonderful presentation.
Oh, thanks. Yeah. No, that's the best part about it, is the fact that there really is no preparation for this. There's no really methodology that it takes to do it. Once that tissue comes, I kind of saw it a little bit in our video, but we took that forceps, we put it on, it's a glass specimen, glass sample holder. And right now we have a screw on top that comes on and flattens the cell. It basically kind of flattens the tissue a little bit, just holds it in place. And we run it through the system, and it uses nothing but light that goes through that. So there's no staining, no prep, no anything, but it maintains. I mean, the only thing, if you do a cryo specimen, just because it comes out as a little frozen ball, you thaw it out a little bit and you put it, and we even thought that cryo may actually not see any metabolism. You may actually freeze it so you don't see anything. And then there's people now like Dr. Mateus out in Christiana who has done a lot of these specimens under cryo, and it finds out that metabolism is still there. And that holds. So even after we're done looking at it, after those couple minutes, we take it out of the device, unscrew it. The little glass ring with the tissues on goes into your formalin or cytolite or whatever you like to use, and it just goes off to pathology. And it goes like that. So no, you don't have to prep it. You don't have to do anything to it, and it doesn't waste. And it goes in there. They find that it goes with the rest of your biopsies, and they find and they can use this part of their evaluation. That's really one of the true benefits of it, is that you don't lose anything to the diagnostic process.
Got it. Something else that we got another question about was when it comes to, and this came in privately. So like in a lot of different procedures outside of interventional pulmonology, there's this like frustration around, like, let's say, an indeterminate biopsy. So essentially in bronchoscopy, as a frustrating outcome, like you have an indeterminate result. Like, have you seen essentially a change in the rate of indeterminate or non-diagnostic biopsies since implementing Van Gogh? And my guess is yes, just because it feels like in interventional pulmonology, the industry was really supported on this like tool and lesion, and then solving this lesion-in-tool problem, like essentially eradicated that. Is that the right way to think about it?
Yeah, that's exactly. So where where we deal with a lot of this changes here is that we've really kind of had to, within our space here, we had to push the envelope to try to minimize those non-diagnostic indeterminate biopsies. We started looking, I mean, even just as early as, early 2000s, or if you have a small lesion, even less than 3 centimeters, which is, nowadays that's big, but back in the old days, back then, it was smaller, that, with a standard bronchoscope and no other technology, your chances of getting that in the best of hands was about 30%. And if it was over 3 centimeters, if it was under that, it was about less than 10%. Now, incrementally, with improvement of technology, whether from navigational bronchoscopy to advanced imaging to robotics to tomosynthesis and cone beam, and as we're starting moving this forward, we've made that yield better and better. We've gone from 10% to 50, 60% to 60, 70, and now we're starting to approach in the 80s and things like that. And when you get into advanced imaging, that definitely helps. That gets you into the, the work that Mike Pritchett and a lot of the guys did around, gets you in that kind of mid 80s, low 90% range. I mean, really start to push the needle. But, but even in those, there's been a lot of images and a lot of things where you can see this needle beautifully inside of a mass, and pathology was indeterminate. They either said it was atypical or they said it was negative. They said, and it never made sense on why that could occur. But now that we understand some of the background, some of the processes that pathology uses, and how we can help mitigate those workflows and help them, give them the most viable lesional tissue that we can get them, that's where I think that this indeterminate piece is really going to start to go away and really start to shine. So that's where Van Gogh takes us. It's that linchpin, I think, that pulls all these different technologies together to ensure that all of them working together to get exactly what we're getting. And this tells us what we're getting.
Got it. Now, something that you did mention in your presentation was where say the first biopsy might have appeared like adequate, but then it turned out to be non-lesional. I think one of the more exciting things about exciting new platforms and technologies like Van Gogh is the ability to essentially like course correct in real time. Can you talk a little bit more about what that's like for you?
Oh yeah.
Because I think that there's a lot of not only new applications, but new environments and workflows that, you know, people in the interventional space have never had the luxury. And then these kind of platforms are allowing for stuff like that.
Yeah, agreed. Yeah. So what I think is kind of fantastic is that, you know, one of the banes of our existence when we start looking at this is actually almost larger masses, because you have larger necrotic masses that you get to. I mean, you can drive to, you can see it in front of you, and you're taking these large, giant pieces of tissue, and it comes back as necrosis. You know, there's cancer there. But back in the days, you would either, again, pathologist sees necrosis, and you take lots and lots of biopsies and hope you get it. And you get to take these big, large pieces. And now it almost looks like you missed the tissue because you didn't get a diagnosis. With Van Gogh, I'll still get those necrosis, but now I'm going to keep digging until I get to the point where I find the cancer. And I know that, and I can do that in the room where I look and I don't see anything. Oh, here it is. And now I know where to focus. So now I'm able, and now everyone can do this. That's the best part. It can exist. You don't need extra FTEs. You don't need advanced trained cytopathologists, where again, you don't have that a lot throughout the country. Whether you're in a rural setting, suburban, urban, academic, you're going to have a benefit of this tool across the board. It really does democratize that. I mean, when you start looking, even the pathology field, you know, I think or a statistic recently where something in excess of 60% of pathologists within the next 10, 15 years are going to be in retirement age. I mean, we're going to get into a world where cytotechs and cytopathologists are going to be harder and harder to come by. So I think that having our ability to determine our own adequacy and our own legionality at the time of the procedure is only going to help us no matter what environment we're in and no matter what size, shape, and type of tissue that we're using. Because this is agnostic to all of it. It doesn't matter the tissue, doesn't matter the tool, doesn't matter the geography or the time of day. This can be utilized exactly the same way every single time.
Got it. Fantastic. Now, we do have an interesting question from Fang Hua, who is a systems vision engineer over at Intuitive. I'm going to read a little bit of the question. And of course, we want to be careful here in terms of making claims and stuff, but I want to ask you more about the collaboration side. So his question was about what necessarily is the expectation of the future of technologies like this? Do you think tissue adequacy tests is the best use case, or can it go further? And I kind of would like you to sort of, instead of answering it that directly, because it takes us down different paths, maybe you can talk a little bit about how a platform like this has sort of opened up the opportunity for collaborations with companies like Intuitive and others, you know, where I think these, perfect example, the Galvanized platform and Van Gogh working side by side to provide really fantastic support to interventional pulmonologists to translate into amazing patient care. Maybe you can talk about those kind of collaborations and what that's looked like.
Oh, absolutely. I think that, you know, to kind of look at this from a technology standpoint, when we look at no matter what platform or company or robot, anything you use, diagnostic yield is always kind of the standard, if you will. We have to that's our, how many times do you get a true diagnosis? And it's been hard to define because of, you know, but one of the things for every study that we have ever done is that we operate under the assumption that pathology is 100% right 100% of the time. And if they didn't see it in their specimen, it means that your robot or your tech it missed it. And where I think the collaboration changes is that there's a lot more nuance in pathology than we ever gave credit for. And there's a lot more art there as well, and a lot more of how these cells are visualized and seen, where they can be in those cell blocks. And that maybe the technology that we're using, the robot or platform that we had, maybe didn't miss it. Maybe we got it more times than we thought, but we just didn't know because we didn't know to ask. We didn't know to look deeper. And we use things like rows and stuff, which can be helpful. But all we ever wanted from rows is to diagnose adequacy. Mm-hmm. The code that Rose uses to bill for, and it's the same one we can with Van Gogh, is that it's an adequacy evaluation. You want to see diagnosis is done in a lab. It's always meant to be done in the lab. So now I do think there's a collaboration amongst all diagnostic platforms and therapeutic platforms gaps. I see that, again, this is the ability to really fine tune to prove that your device is as accurate and as effective as you believe it to be. And really the stakes are what you're seeing, what you're finding at the time of the biopsy, and the effect that that tissue is having on the therapeutic side of it. Now, the question, I know, kind of, if I had to put on my hopeful hat and see where things go, yeah, you've got fantastic images of metabolic activity that you've never had before, and we exist now as our ability to, incorporate information with, and as artificial intelligence improves and all these things, you start to see patterns like, yeah, this would be fantastic to see where this could go when all of these things really start to come together like that. I can find that, so I would love to see, and then I can tell you the team at CellTivity too is constantly innovating and evolving and kind of moving in this space and really trying to open this up. And the other great part is this is not just lung. This can be used anywhere. I mean, it's tissue agnostic as well. And they've got imaging across multiple organ systems and in the transplant space. And the thing, I mean, there's modes above and beyond even just what we're starting with now. And that's the excitement across the entire field of medicine with this allows.
Yeah, absolutely. On that same note, something I was wondering about is when it comes to, let's say, downstream testing, which is really, we've seen a big boom in it with it, especially like with the advent of AI. Specifically, I want to focus on like an NGS.
Mm-hmm.
How has the system essentially impacted, let's say, your ability to ensure that you're collecting not just any tissue, but the right tissue? Yeah. And I think that's like really key here, because one is solving this time delay of like collecting the tissue, sending it to pathology, and it being the wrong tissue and everything, but then also interoperatively in real time, making sure that you're getting the right tissue, because those, those seconds compound over time. And so how's that impacted your procedure and workflow?
Yeah, no, it's been, so yeah, it's kind of fascinating, because when in order to get adequacy for next generation sequencing, you have to have a certain number of cells there, and they have to be number of cancer cells. And again, not knowing what's in the lesion, you don't know that depending on how many biopsies you get. So we were doing these qualitative assessments, real kind of big picture, like, oh, that looks like a lot of cells, and I think we got enough for this. And then another poster that was presented was from Dr. Kyle Hogarth in Chicago, where he had his fellow actually, because you can do this with fellows, manually count each cell that was in a specimen. And they took a swath of those, and they had an assessment. They basically said, we have this X number of cells. This will be enough for NGS, and sent to pathology. And so they knew it was malignant. They knew how many cells they had there. He had Rose in the room with him next to him that could help confirm like the actual presence of cancer. So when they were all counted, 100% of his ones that he thought in this small group all came back as adequate for NGS. So now this is going to be a big game changer for that when it comes to, because many times, we have to go back and rebiopsy people just for that. Even when you get a diagnosis, like, well, we don't have enough for NGS, so we got to go back and get more. But even when you're getting more, you don't always know you're getting enough, because you don't know how many that is. Now, again, but now the system itself is starting to build an algorithm that's going to start to do this for us, where actually it knows which cells, again, when it knows which cells are abnormal, it can tell you how many of those are there, built into the volume of it. So I think what's going to find is that we're going to help us dramatically at the time of biopsy, if we're concerned about cancer, know that we have enough for NGS. But even if patients, let's say, we didn't see before, and we have to go back, if they're sending us the first time that oncologist wants us to biopsy for that NGS, we're going to have a much better idea at the time of the procedure that we're getting enough for that, so that they're getting those answers as quickly as possible.
Got it. Now, something that I'm, very curious about myself, and again, for those who are still watching the stream, we're still taking questions. We're getting close to the top of the hour, so we're gonna get your last questions in. For me, when I look at like really exciting platforms like the Van Gogh, and of course it's capital equipment, I want to shift gears a little bit more to the administrative side, right? So from a hospital perspective, when you look at, let's say, diagnostic yield and reduced repeat procedures and then staff utilization, where do you see the most value that the system's able to bring overall? Because again, for somebody like yourself, you wear multiple hats. One of those is a clinician. The other side is actually thinking like a business person, an operator, because you have to be able to translate that to the hospital admin, right? Absolutely. At the corporate level.
Yeah, I can tell you that when, so that it's a couple different factors involved with that. One of it is that there is a small reimbursable component to that. So the disposable itself, by doing it without having a cytopathologist in the room doing rows. Remember, rows is an adequacy assessment. So I can any clinician in the U.S. CMS kind of detached, having to have a CLIA lab to be able to do an adequacy evaluation. You still need a lab in order to do diagnosis. That's a different code. But for an adequacy evaluation, which, in the US pays an RVU, but it covers the cost of disposals. You can do that. You can do that with several sentences. You can say if it was adequate or not adequate. You're allowed to make that assessment. That's our coders found that. I didn't, they picked that up. So there's that piece. But again, there's also the other piece regarding time savings. Time saving, again, has become a very hot button topic for administration. When we evaluated the CellTivity technology, we had to sit in front of a value analysis team. Every hospital has these. And I was doing my presentation before ever using this tech. And I said I was going to be able to add a case on with this. And I remember one of the accountants gave me a real hard time, just like really hard time, because there's clinicians, accountants, administrators, and everybody on this. So we had it for 6 months, and we did, 100 some cases. And we actually proved at the time, just by looking, we on average saved about 30 minutes wheels in, wheels out time, even beyond just the procedure. And we actually did add an extra case on a day. We started to look at that. So when we came back to reevaluate, he said, I have to give you an apology, because I can't tell you how many hundreds of doctors that sit in front of us committee every single month and tell us that they're going to add an extra case on. This is the first time that you've actually done it. And that to us is huge. So by minimizing OR cost time and those variable costs involved with some of these extended procedures, and then being ability to add a volume on, add an extra case on, becomes, again, those are type of things administration really loves to see. But I also think too that, the nice part about companies like CellTivity is they're very nimble in their strategies. And I think that, with a lot of different, there's a lot of kind of big ticket items coming out now with they're doing a lot of good in this space, again, with robotics and imaging and therapeutics, that, the company sees the importance of this and where this leans into. And I think that they're also willing to work with hospitals administration to really bring this device that's going to prove a true quality of care for every patient that you see to the masses in a way that's going to work for everybody. So I think that there's a good back and forth with that you rarely see with kind of hospitals and industry. You're now really starting to see that come forward.
Absolutely. We got a question from Dr. Quinn, who's a thoracic surgeon. His question is, has anyone used this during a lung resection to make sure resection margins are free of disease?
Yeah, it's a tricky one for margins, because again, it's kind of designed still to look at small bits of tissue. I mean, you can get a lot on that little piece, but it's hard to tell for margins. But where you are seeing it used for thoracic surgeons, which I find is interesting, is that when they're starting the process of like a single anesthetic event, they're going to diagnose, they're getting ready to resect, and when you're sending out for frozens or you're doing those initial pieces of margin, a lot of times you're waiting for pathology call back, you're waiting. So what they're doing is they're taking that, whether they're taking a part of their resection and taking a piece of that tissue, putting it on Van Gogh, looking at a small area of it, showing that it's cancer. No, okay, all right, they're going to find cancer on this. No, I'm going to start getting the patient prepped, go from the diagnostic part to the surgery part. So they're getting them rolled, they're getting them ready. So when they call back and show that is cancer and is there, and then it allows them to kind of move forward in that procedure. So it's really beneficial kind of earlier on in the kind of diagnosis to resection piece of it. But I do think as time goes on, and as this continues to evolve and kind of do bigger and bigger things, start looking at that, you'll be able to get enough volume for margin. I think though, but this being more of that kind of point of care adequacy assessment, it's a little tricky to get margin from that. But there still is places where it can help speed the thoracic surgical process along for you to make your procedures efficient in other ways.
Got it. That makes sense. I'm going to ask everybody just get in their last questions. I have one more for you that I wanted to ask about. So when you think about adopting any new technology, it's always exciting because of the value it brings to patients and of course your workflow and everything, but like it's changed whether you like it or not, right? And so I'm wondering how you and your team essentially adapted to the change of adopting something like Van Gogh. Were there any specific like learning curves, and then how did it essentially integrate into your like existing bronchoscopy workflow?
Mm-hmm. Yeah, for us, a lot of it, I think change comes best when it's solving pain points. And one of our biggest pain points was when we would robotically get to a nodule, get a biopsy, and we're all standing around waiting for pathology to call, because we know. And then they would call and they'd say, well, I can't tell. It's I see a couple maybe atypical cells, depending on what pathologist was on, depending on what I saw. If they didn't call, links up front, then we're doing it again and again. So I'm standing there, my staff is standing there. This became a huge pain point. And even after we well, I got enough. I think I got, we got. And then when we're all done with that, and then they call back and they would say that, oh, it was non-diagnostic, or we'll say something, now you have the pain point of having to have that conversation with the patients. It's even worse. So for us, by looking for a technological piece, and I initially thought, before I ever met before I ever learned about CellTivity, is like, well, I got to find something easier for pathology. Maybe, we've got to find a process for them. But this device was the first one I ever saw that was actually built for me. It was built for a proceduralist. So allowing me to do this and look at this and actually do it in a fraction of the time with a higher level of accuracy for adequacy, because I also have the clinical context, again, to know why I'm doing that. I know what I'm looking for, more so than any pathologist that has no clinical context, only looking at a small piece of tissue on a slide. I know why I'm there. So by knowing that and allowing to evaluate that, it fixed that pain point. And my staff took ownership of this. They thought this was extremely easy to use, very user friendly. So they run it now. Anytime, if the CellTivity team is there, it's great. If they're not, my team can run it very well. We also outboard those same images onto monitors in my room. So I have got nurses and techs and people with even limited pathology support. They'll look up at the screen, like, oh, you got it. Like, they know. It becomes that user friendly, that instinctual, as we're seeing this. When you start seeing those patterns, the learning curve is extremely short with that, because again, if you see cells that are metabolically active yellow and they're large and they're different shape and they're clustered together, those are factors that pretty much lean into a very high probability of malignancy. And even if you don't know what it is, if you see something that's not blue-green, it's not normal bronchial cells, you're in the right spot. And that's all that matters at the end of the day.
Got it. Fantastic. Well, it looks like we don't have any more questions. Dr. Kovacs, I want to be very mindful of your time. I want to thank everybody for joining again. If you're watching this on replay, you can feel free to leave a comment and a question. Somebody from CellTivity will be able to follow up with you to answer that. And for those who are listening, let's say on the road, be sure to go to the website. You can learn more about CellTivity, read a lot of their clinical papers and more. Go to celltivity.com. So that's CellTivity.com. Thank you, Dr. Kovacs. And give Dr. Kovacs a follow. He's active on LinkedIn. He puts out some great content there.
Thanks so much. Pleasure talking with you. Appreciate the opportunity to speak with you. Just a lot of fun. Thank you.
Fantastic. Take care, everybody. Thank you, and have a good evening.
We'll see you.